Thanks everyone for calling in or joining via web. I see that I think Columbia Med School has joined. Maybe they're watching it as a group. I want to introduce Dr. Weisbart. Dr. Weisbart's the chair of PNHP Missouri. He's given many talks on single payer. He's led wonderful workshops at the PNHP annual meeting. Other than chairing PNHP in Missouri, he's also a family.
Oh, we're listening to it.
I watched him give a talk similar to this at the PNHP annual meeting. So without further ado, I'll hand it over to Dr. Weisbart.
Hey, thanks, Cal and Tony. I appreciate you guys doing the work of putting this together. It's a lot of work organizing it, and I appreciate that. And I appreciate SNAP inviting me, and I appreciate all you folks giving up part of your evening tonight to listen in on this. I presume that means you're as passionate as I am about the topic of how to really kind of try to fix healthcare in the United States. So we're going to run through basically two parts of this tonight. First, we'll spend some time talking a bit about just Medicare for All in general, doing some highlights on that so that we're on the same page. And in particularly, I'm going to point out some things about Medicare for All that I'm going to reference to in the second part of the discussion so that you have the basics that I'll be mentioning. In part two, the second part, we'll be talking really more about the topic for tonight, which is how to communicate this stuff, how to message it. And it's interesting because there's so much information about really how to communicate about controversial topics, which we often so totally ignore. And as a result, we wind up getting sidetracked on issues that are adjacent or not even remotely connected to what we're intending to talk about. We wind up tripping landmines and radioactive topics and doing things that we really didn't want to be talking about. And as a result, we then don't find the common ground of where we actually have quite a bit of agreement with folks. So that's what the thrust of this will be about tonight. So I am, as you heard, a family physician. I practiced in Chicago for 20 years or so, delivering babies and taking care of old folks and everything and all that stuff in between. And then I moved to St. Louis, as I'll explain in a moment, and started also volunteering at a safety net clinic here at Washington University, where I go out usually once a week or a little bit more than that. So I volunteer at basically free clinics these days. So my practice in Chicago was, as I said, at a large urban academic medical center. And it turns out when you're there and spend most of your time in that kind of a setting, you're kind of surrounded by similar thinking, relatively progressive people, more or less, not completely. But conservatives were sort of a less common breed in our group, and a lot of us were in our little bubble and had imagined conservatives were these less informed or ignorant or indifferent and cold-hearted folks, and we had these cartoons of what a conservative was, and that was actually not accurate. I moved to Missouri and found quite a bit of a different culture meeting me here. So I moved to Missouri, to St. Louis, to be chief medical officer at Express Scripts, a Fortune 100 company that's basically a pharmacy benefit manager. And this is being a large part of the Fortune 100 company. It's a lot of the folks there are far more conservative than whom I had dealt with previously. And I had to reconcile the fact that this cartoon I had in my head of conservatives was actually totally wrong, totally wrong. Most of the people that I met in this much more conservative setting were actually incredibly decent human beings, very generous. They donated more of their time and money to charities and good causes than I often did. They're well-educated, knew a lot of stuff that I didn't know about history in particular, and they were trying to often do the right thing. So I had to reconcile that, and we'll explain more about how to do that in a bit. And then I retired from that position in 2010, and a couple of years later was coerced into organizing the originally St. Louis and then the Missouri chapter of Physicians for a National Health Program, which I believe you're all familiar with, and I won't belabor that too much more. We started 5 years ago now with about 100 people, and now we reach almost 4,000 people across Missouri. And you know the drill of what the organization is about, and you're part of the student arm, so to speak, of the organization. So let's start by just sort of setting the basic sense of what Medicare for All is And I'm going to, again, talk about it in a way that I think crosses political boundaries and may not be the way you're used to thinking of it. But I think of Medicare for All as truly a free market solution. And I think that's important because one of the common conservative complaints is, well, we can just let the free market take care of this instead of doing what we're proposing. And my point is that this is a free market solution. So what do I mean by that? Well, there's looking around the world to really oversimplify this. There's three ways that healthcare is organized. One would be a national health service, and this is publicly funded, tax dollars, publicly delivered. So this is how the Veterans Administration does it. This is how Great Britain and a variety of other countries do it. This is, by definition, socialized medicine. It's one of the three common ways that healthcare is organized around the world. Socialism, as you recall, is defined as the government owning the means of production. So since in the National Health Service, like in Great Britain or the VA, the government literally owns the buildings and directly employs the physicians, that is, by definition, socialized medicine. And it exists, and I imagine, there's plenty of good evidence that it works well in certain settings, and it is not what we're here to talk about tonight. So that's one model, and it's not the model we're here to talk about. The other model you could talk about is what we have. Wild, Wild West health insurance is what I call it, but that's the multi-payer model that you're familiar with. We're the only country that does this. I consider these two models to be extreme, and I call them extreme because, number one, on the National Health Service side, I don't call it extreme as a value judgment, but I call it extreme because it is as far into healthcare finance and economics as a government can go. So when you're doing it as far as you can do it, that's sort of an extreme version of it. I call our version of the multi-payer Wild Wild West health insurance, I call that extreme too, because we are literally the only country in the world that organizes healthcare in the way we do. And when you're the only one doing something, again, not saying it's bad or good, but when you're the only one doing something a certain way, that's extreme. And I frame it with these two extremes because there's, in my mind, a conservative model right in the middle, which is just national health insurance. We're not talking about having government involved in the delivery of care. We're just talking about the finances, turning the insurance into a utility that we all have access to. So by definition, then, it would be publicly funded by tax dollars. It would be privately delivered, as much as it is today. Now, this does not directly address any of the issues on the delivery side, and there are plenty, but we're really only talking in this model about the financing side of it. So that, as you know, is how Medicare works today, where it's primarily tax funded, but then privately delivered through a whole wide range of physician delivery models. That's also exactly how Canada sets up their system and a variety of other countries. So I consider that a conservative model in the middle because it preserves the delivery side that we are attached to in many ways. I consider this a free market solution in the sense that under today's system, doctors are competing with other doctors for the most lucrative insurance contract, and patients are often compelled to choose their physician from within the network that insurance contract that their employers picked offers. This, on the other hand, has doctors competing against doctors to attract patients, and has patients in complete control of which physician they see. So it's really applying the free market, absent the financial barriers of the free market. It's applying the free market to the delivery side of healthcare. So I consider it a free market solution. Turns out, as you probably know, that there are bills pending in Congress. There's in the House H.R. 676, the Improved and Expanded Medicare for All Act, and then there's a similar, although somewhat different bill pending in the Senate as well. So we'll talk about those a bit. We'll talk mainly about H.R. 676. So it, as you probably know, is the bill that does improve and expand Medicare, and it's 32 pages, I think it is. It's short, it's double-spaced, kind of a big font, it's easy to read, and if you have not yet read it, I recommend you tonight, when we get off the phone, you go and Google H.R. 676 and read it. You'll find it's easy to understand and that there's really only two things in it: improve Medicare and expand Medicare. So by improving Medicare, we mean fixing the benefits, because the benefits today have some gaps. It doesn't cover dentists, doesn't cover hearing aids. There's a variety of that Medicare, when it was set up, didn't really include. So improve it in that way. Put in the things that we know people need, and get rid of the financial barriers to care. Medicare, as you know, has pretty significant copays and deductibles. And so as a consequence of those two problems, the benefit gaps and the financial barriers, many seniors who can afford to, actually a third today, are purchasing a Medicare Advantage program, or they're getting a supplement or something to improve Medicare on their own. So what we're saying is put those improvements, the improved benefit design and the elimination of financial barriers, copays and deductibles, put those improvements into traditional Medicare, Parts A and B, and then you would no longer have a market, frankly, for the Medicare Advantage programs or supplements or wraps, because everybody would have these improved benefits. And then expand it to everybody, expand it to all Americans, including Congress, the mayor, the teachers, coal miners, every profession you can think of, every job you can think of, employed, unemployed, give it to everybody. By having everybody in it, you accomplish a number of important things. The number one thing is that then it is the most sustainable program. It then becomes a program that if somebody tried to damage, they would be damaging, a legislator tried to damage, they would be damaging healthcare for their families and their friends and for everyone. We would not be fractionated into these little subgroups that can all ignore each other. The second reason why it's so important to expand it to everybody is that that's the only way to get to the economics that we need, the finances that we need. And we'll walk through that a little bit later tonight. So improved and expand Medicare. So I'm calling it Medicare for all, but you've also heard the phrases single payer and national health insurance. What are we talking about? So here's the way we usually think of healthcare. There's all the Americans on the left of your screen, and then on the right is all the stuff that we want. We want doctors and hospitals and pharmacies and stuff. And in between, though, which we need to think about, is all the money, of course. So how do we manage the money today? We manage it through all of these payers. So there's the United States government, right? We pay our taxes, and then the government employs the military. The government pays for most of Medicare, and with states pays for Medicaid. So the United States government is one of the payers. States are payers. Cities are payers, businesses, schools, and of course the myriad insurance companies. So today we have literally thousands of payers. It's a complicated system. This complexity is expensive, and that's what's called a multi-payer system, very expensive and very much with gaps where people aren't covered at all. So that's a multi-payer system, and we're saying you could fix that by replacing all of that with a single payer, where we would pay our taxes and it would go into a fund that's managed quasi-governmentally, and then that fund would then pay for all the things we need. So that would be one payer. Now, you now understand what we mean by multi-payer and single payer, but I'm not sure you would have, or many of the people you're talking to know what that phrase means otherwise. So that's what we mean by a single payer. That's also, of course, what we mean by national health insurance, because it's insurance for the whole country. And it's also what we mean by Medicare for all in general, because we think in our organization that the most prudent way to do this, the easiest way to do this, would be to indeed what I talked about, improve Medicare and expand it to everybody, build it on the 52-year-old highly successful model of Medicare. So don't have to take my word for it. Turns out that there's actually a huge non-randomized but controlled experiment that's been going on since 1971. So before 1971, America and Canada's healthcare systems were very similar, actually, and their performance was very similar. Both of our healthcare systems were costing about the same percentage of our GDP, and we had very similar life expectancies. And then we had a change. So we were the same, and then in 1973, President Nixon signed into law the HMO Act, and ostensibly to reduce the cost of healthcare. And in 1971, actually, Canada fully implemented their national health insurance program. So we were the same, and then we went down managed care, and Canada went down the side of essentially Medicare for all. How did that pan out over the next several years? Well, here's the data about our costs, and you've seen data like this before. Our costs are continuing to climb, getting near to 20% of our GDP. You've seen that. Here's where the HMO Act was passed to reduce the cost of healthcare. It doesn't seem like it really did that. And then here's Canada's chart, and you probably haven't noticed this one. So notice, until 1971, we were the same, and then we embarked upon two different national healthcare policies and huge fork in the road financially. Also a fork in the road on our unmet healthcare needs. So today, 14% of Americans would say on this study that they have an unmet healthcare need, but only 11% of Canadians would say that. In the United States, some of us have it because of a waiting list or a service that's unavailable, but most of us who have an unmet healthcare need is because of the cost of healthcare, and then a smattering of other reasons. Canadians, it's because of a waiting list primarily, and we'll talk a little bit more about that. And then there's some who have a problem with cost. The Canadian system is far from perfect. For example, it doesn't cover a pharmacy benefit, and a smattering of other reasons. So what about this waiting list issue that you hear so much about? How long are these waiting lists? And if you listen to most Americans talking about it, you would think, oh my God, the Canadians probably wait, I'll bet 80% of Canadians wait like 2 years for surgery. That's kind of the general sense. Well, let's look at it. What are the differences actually? In Canada, there is a waiting list actually. If you look at the median data, knee replacements take almost 4 months, hip replacements over 3 months, cataract surgery, and non-emergent angioplasties and bypass can take as much as a week. Well, that's a waiting list. People don't like that. What's the data look like for the United States? Well, it turns out that there is no central repository for this kind of data because we are so fragmented. So how do you roll up the data a little more broadly? Elective surgery, 80% of Canadians wait less than 4 months. So you're going to have anecdotes of somebody who waited longer, but 80% waiting less than 4 months, not so bad. And if you look at how it is in the United States, well, you can't because we don't actually have comparable data for that. Now, the main reason Canadians have this waiting list, of course, is because, as I've shown you already, they spend half of what we spend. So how important is this waiting list? Does it mean that they're all sort of dying prematurely on the waiting list? Well, let's look at that. In 1979, as far back as this particular data set goes, Canadians were already living about 1 year longer than we were. I'm not sure why, but 1 year. And now as the experiment has continued, they now live nearly 3 years longer than we do. So no, the waiting list is for the minor things, and it's although there are of course anecdotes, it's not the life-threatening things in general. So I'd say it's time to stop this experiment. They spend half of what we spend. They have fewer unmet healthcare needs, and they live significantly longer. There's also a ton of data about the economics of this. It turns out that there have been, and I've counted them, 25 studies, and there's probably more that I didn't find, that show that the savings of doing Medicare for all would at least fund, if not greatly outweigh, the new costs. So I'm going to walk through one at a high level. It's public domain, and you can get access to it at the reference. And this particular analysis shows that, of course, there's new costs, but the new savings would be greater. So what are the new costs? Well, if you put everybody into Medicare and paid the same for every patient, of course, you'd have to pay more for Medicaid because, most states today reimburse Medicaid profoundly less than they do for Medicare or commercial insurance. So there would be a cost to that. That's probably a good thing. I'm, like most physicians, really aggravated and tired of having to assess my patient's economic value to me before I let them in my practice. We don't want to do that. So we have to pay more for the Medicaid patients. It's about that much more. We'd also have to pay something for the uninsured. And of course, people would start doing some things. They'd go to the dentist, they'd get home health. So there are new costs. But there are also new savings. So the government would only be administering one program instead of the many that it administers today. So there's some savings, but it's pretty trivial. There's a huge savings in the cost of health insurance administration. And then, of course, the average physician today, according to a Milliman study about 2 years ago, the average physician is spending about $85,000 on office staff who do nothing but manage the insurance industry. So administrative savings to physicians and hospitals would be significant, which means you could make a small bump down in what you pay physicians on a fee schedule and have us stay whole. That's not a bump down from Medicare. That's a bump down in our total annual revenues and have us still stay whole. Of course, Medicare is not the fee schedule we would go to. We'd be negotiating that. And then you'd, of course, be negotiating market power. Let Medicare negotiate the prices of drugs and devices. So at the end of the day, there would be new costs, but it's disingenuous to say that those new costs are unaffordable when you look at the huge savings that virtually every study shows. So one of the last things I want to make on this baseline data is that it's remarkable how many Americans today are so fed up with the system here that they actually travel overseas for their health care. Nearly 1 million travel overseas for the cost of health care. They do it because it's cheaper. And what do they go there for? They go for things that we like to think we're the best in the world at. And they go to countries that we like to think we can do at least as good a job at. But because of the cost of health care, they're going overseas. And I have to ask if traveling overseas or importing drugs or whatever is really the best healthcare strategy for the United States. I would like to think we can solve that better on our own. So that's the baseline stuff. Let's talk a bit about the messaging piece, because it turns out that the words we choose to use really matter. And I'm going to, so we told you about the phrase of Medicare for all versus single payer versus national health insurance. Which one of those phrases should you use? Well, we walk you through this so you know what a single payer is, you know what all these phrases mean, but let's look a bit at how these words resonate. So single payer, you now know what a payer is. So when you say single payer, you know precisely what you mean by that. Most people don't actually know what a payer is, let alone what single payer would be. So when you use the phrase single payer, you're actually just tapping into the emotional baggage of, well, that's communism. Well, that's socialism. Oh, single payer, that's what us liberals like. You're just tapping into the baggage. And for most people, you're not actually getting to a substantive discussion. So I would say the phrase single payer is one you can use, but use it selectively and only in audiences that know what a payer is. National health insurance, I promise you, it's not a phrase you should use here in Missouri. Missouri, anything that sounds like the role of the federal government does not resonate outside of small circles. So be careful if you use that phrase. And even the phrase Medicare for all, you've got to be a bit careful with, because there are some groups that are really focused on, well, Medicare has these deductibles and copays. So the right phrase, I guess, really would be improved Medicare for all. Don't forget the word improved. But in general, I don't make that long of a statement. I just say Medicare for all. And then when somebody says, but Medicare's got these problems, I say, oh, you're right. I should have actually said improved Medicare for all. But I would say the phrase Medicare for all or improved Medicare for all resonates better. That's not just my opinion. There's actually data. So here's surveys, Socialized Medicine, and I've spoken a few times to Democratic Socialists of America, actually, and they like this phrase quite a bit, and it scores a bit higher than I might have thought. Single payer doesn't score too much differently than that. Guaranteed universal coverage scores much higher. If you say that phrase, people really do kind of like that. But the most successful phrase, according to the data, for the whole population, not for individual groups, but for whole populations, is the phrase Medicare for all. That's pretty recent. So I want to walk through a few models of how people think, and this one will be contrived because you're not actually here. So here's one model. We'll play this pretend game where this will sound off topic, but it'll become very much on topic. We'll play this game where we're going to toss a coin, and imagine that you and I are tossing a coin, and heads, you're going to lose $100, but tails, you're going to get something from me. So the question is, for you to actually say you're willing to play this coin toss game with me, where you might lose $100 if it comes up heads, how much would you have to gain to be able to actually say, yeah, you know what, let's play? Heads, you lose 100. Tails, how much would you have to gain to be willing to play? Well, the most common answer is $200. Losses in general count double of gains. Sometimes I've had people say, all kinds of other numbers, but I've done this a lot, and losses generally count double of gains. It's been done all over the world in barter societies with goats and sheep. Losses are more important than gains. What does that have to do with anything? Well, think about how we phrase things. So you're taught in med school to be very gain-centric and positive and touchy-feely, but loss-centric messages are twice as potent. So gain-centric messages, save money for things that you want. Loss-centric, stop wasting your money. You don't have money to burn. Gain-centric, see any doctor you want. Loss-centric, why should somebody else tell you who you can go see? Gain-centric, you can live longer, you'll be healthier. Loss-centric, don't die younger than you need to. So think about gain-centric and loss-centric messages. Another model I want to talk through is this model called the whole brain model by Manny Elkind. And he says that people have one of 4 comfort zones that they favor. And you can do personality tests and find out which one is yours. You can go online to his website and find it out. But you have one of 4. We all have all 4 of these, but you have one that you tend to prefer the most. So what are these? Some of us are most comfortable in the world of facts. We want to know the numbers, efficiency, measurements. We just want the facts. Others of us are much more comfortable with the process, the form. And another group really just wants to know where we're going. And the last group has to know about people, the human side of things. So some people, in other words, if they don't have the facts to hear about, they're not going to be able to understand what you're talking. Other people, the facts are not important. It's more about how are you going to do it. If you can't tell me how you're going to do it, I don't care about anything else because it's just a pipe dream. Others, if they don't have a clear sense of where we're going, they also can't relate to what we're talking about. And the fourth group, of course, if you don't have a human face on this story, I can't relate to you. I can't understand why you're talking about this if it's not got a human story. So think about that. Think about where you're the most comfortable, and think about how to put that in terms of messaging, because you have to get outside of your own comfort zone when you're talking to folks. So if somebody comes at you with facts, in other words, they're asking you about life expectancy, or it says we can't afford it, or something like that, you have to answer in kind and talk about facts. But somebody else who's saying, well, how in the world, you don't have any way of doing that. How can we possibly accomplish it? For that person, if they say that this is really unachievable, you can talk about, well, there's actually legislation pending in the legislature. Or you could say, well, we have Social Security. Social Security finds you at birth, and then when you turn 65, Social Security finds you again and starts mailing you a check. We have this system. So why not, in addition to what it does today, why not say, have it be run through Social Security? So something about a process of how you would do it. That's not the argument for everybody, but for the people who are concerned about how you would do it, those kinds of things get them more connected to it. Of course, you need to be able to talk about the future. Where are we going? And lastly, some folks really just need to hear a story, the anecdotes about where we're at. So if you're getting somebody who's talking about anecdotes, they're in that fourth quadrant on the bottom right, and they tell you about their uncle who died on the waiting list in Canada, and you answer with life expectancy data, you're making the wrong argument. You've got to try to come up with anecdotes and some sort of a human feeling story that's in alignment with what they're saying. And then, of course, you can broaden it to the data, but you've got to try to stay in their quadrant, not necessarily the quadrant that you want. So you figure out where they are by listening to them. Another model I want to tell you about is from a neurolinguist from Stanford called George Lakoff. And this was actually my first entree into the how do people think about this stuff. And this is, I think, one of the premier books for you to read. It's called Moral Politics. And he has others, one called Don't Think of Elephants, and there's a number of others, and he's got a blog you could follow. But this is sort of the one of the pivotal points in this. He says that people have one of two models in their head, and that these models are established in childhood based on our environment as we're growing up. In his words, nurturant mother or strict father. These are, again, his words that I'm just quoting for you. Pardon me. So a nurturant mother, he says, is somebody who believes in equality or diversity or in the helping hand of, the level playing field kind of thing. And that's what he says are where most liberals have as their primary frame. Strict fathers are more focused on the hierarchy of things. They actually have this sense of a natural hierarchy of, I think he says, God, man, woman, child, animal, plant, rock, with subdivisions probably under that by all kinds of issues that we are too horrible to think about, but hierarchical models. And that your place in the hierarchy is driven by your moral value. And so a system that disrupts this hierarchy is actually very destructive to society. This is the strict father model, basically social Darwinism. That consequences are hugely important in this model. This is more common among conservatives, of course. And the thing is that there's this group in the middle that have both of these frames in their head. If you don't have the frame in your head, you won't be able to hear the argument that's coming from this camp. So people that have two frames, have both frames active, they look undecided, and politically they might be more in the independent category. They may classify themselves as liberal or conservative, but they have more of a tendency towards being really bimodal in their way of thinking. So the important part of this is that Lakoff says that 20% of Americans have only the liberal nurturant mother model in their head and almost can't hear this social Darwinistic point of view. They almost they can't understand it. He says that 20% of Americans have only the strict father model in their head and really can't understand the nurturant mother side of things. No matter what you say, they can't understand it. But that most Americans actually have both of these models in their head. So what do you do with that? Well, I'll tell you what I've sort of started doing with that is first try to figure out to whom you're speaking. If it's someone who tends towards the liberal camp, then you can move them forward, see if they have a gap in their information that you can help with, but ask them to move forward and take commitment and make and action. Try to get them to commit. Conservatives are not people that you should abandon by any means. They have these values of consequence and freedom and prudence. So messages that work more with conservatives I think, are to talk about how your choices are being limited by the insurance companies. You are losing, insurance companies rob you of the control of your decisions about your own health care. You can decide if you don't want to get health care. This isn't the nanny state making you go get your mammogram if you don't want to, but you shouldn't die because you can't afford care. And lastly, it's so wasteful to not to make somebody go onto dialysis because we're unwilling to purchase to help them afford their insulin. So we're doing our healthcare in the most expensive way we can. So those are messages that I find work there. With independents, this is more a group that actually does want to agree with us in general, but they have questions, so help them with the content. And then make liberal, so to speak, use of stories to try to activate that nurturing frame. Use the story about your grandmother or this patient you saw or somebody that they would want to care about. Ask them about their grandparents. So that's how I use that. Another model I want to talk about is from Jonathan Haidt called The Righteous Mind. Spectacular book. I think of this as Lakoff 2.0. It's more sort of obvious about what the evidence is. He did this online survey of now north of 200,000 people, but at this point that it was published, 130,000 people. And he assessed where people were politically, across from the very liberal to the very conservative, and he identified what he calls 5 moral pillars or moral values. So, and then he connects these two. So the 5 moral pillars that Jonathan Haidt mentions are fairness, which you can see defined there, and caring, also loyalty, authority, and sanctity. So he defines these in some detail in his book, but fairness, caring, loyalty, authority, and sanctity. So how do these values rate depending on where you are politically? Well, if you're very liberal, you probably score very high on his assessment of fairness. If you're very liberal, you probably score very high on his assessment of caring, but you score lower on loyalty, authority, and you may actually even reject some of these values. On the other hand, if you're on the other far extreme of very conservative, you still accept and endorse fairness and caring, but not nearly as in such an isolated way as the very liberal tend to. But you score these other things much higher. Isn't that fascinating? So if you're standing here on the left, looking at somebody far on the right, all you see, because loyalty and authority and sanctity as moral values to you are actually invisible, and you're looking at just the fairness and caring moral value, and you're seeing a lower endorsement of that. And so from the very far left, looking to the very far right, it looks like they're just unfair, uncaring and indifferent to fairness as a value. And that's not true. On the other hand, if you're on the other extreme and looking towards the left, you see a very low score on loyalty and authority and sanctity, and you view this as an amoral problem. So both sides think they hold the moral high ground, and they're both right and they're both wrong. So the point is to try to avoid this. And how do you avoid this set of issues? Well, we love to say this, right? When we're talking about fairness, we love to talk about healthcare as a human right, and that resonates because of the high value of fairness on the left. We also like to talk a lot about protecting the vulnerable. These are the 2 core values of the very liberal, and they are not rejected by conservatives, but they're not going to be persuasive. So when we make these arguments about that, we're not going to win any arguments. And if you look at memes like this that we've seen all the time, the outrageous salaries in my mind of what some of these corporate executives make off of healthcare, these memes like this resonate well with people on the left. Look how unfair that is. But people on the right, it's social Darwinism. That's, they're there because they have their moral value puts them up there. They deserve it. The point is, you can't win that kind of an argument, and you don't want to engage in that argument because that's not the argument. So instead, think about values that do cross this border. Loyalty. If we talk about poor outcomes, you have to come up with a reason for pride. If you say things that are damaging to a very conservative view of the United States of America, they will stop hearing you, and you have to quickly go to something that they can be proud of. This is not a thing that you can be proud of. You can't be proud of people having to go overseas for their health care. So if you bring that up, you can say things like, we can do better. We Americans can do better than this. We know how to solve our problems. So think about a reason for national pride. Align with faith leaders. They're a huge authority source, as are physicians. And there's no end of quotes you can use from them, and I'll give you one near the end of this. And then, of course, sanctity of life. Talk about keeping us out of poverty and extending lives. The last one of these models I want to talk about, which almost sort of overrides all of the others, is tribalism. So we root for our sports teams, right? There's this book called Moral Tribes by Joshua Green. And he says this is what's happening in Congress, that, you know, it's really not about nurturing and Lakoff's model. It's more about tribes. And that's what happens in the boardroom. That's what happens in a lot of places. And he says, he makes a pretty compelling argument that our brains were designed for tribal life, for getting along with a select group of others, us, and for fighting off everyone else with them. And if you think back over millennia, this is how it's worked, right? You know, we've come together as small communities and we fight to protect us, and we're often fighting against them for our resources. So tribes, you know, a genetic tendency towards tribalism is built into the wiring of our brains, and it comes up all the time. Sports teams, for example. So what appears to be a philosophical opposition is really to big government, he thinks, is really just tribalism. Government programs like Medicare, which very visibly and directly help us, the word us, are sacrosanct even among social conservatives. So I'll give you one good example. I gave this talk at the PNHP meeting a few months ago, and then we practiced it. And one of our participants said this as her example. She said, here's what she was going to talk to the Chamber of Commerce in her town, and this is how she was going to start. She said, most of you know me as the neighborhood pediatrician, but you may not realize I also run a small business. And I thought that was brilliant. So she said, I'm in your tribe. When they thought of her as a pediatrician, they thought of her as a caring liberal. They didn't realize she was actually in their tribe. She tried to show that she was in their group. Lakoff would say that she's tapped nurturing and hierarchy, and the moral pillars that she's tapping here are loyalty and authority. So it was pretty brilliant, one sentence. Let me try to walk through this kind of quickly, how you would actually do this. So here's some examples of actually what you would say. Medicare means making Americans healthier. So this is my wonkiest chart, and I'm going to actually skip this for time. So if you haven't seen that, we can show you later. This is a chart going through overhead. So this is the overhead of all the different insurance companies versus the overhead of Medicare. And the way to think about this is that we're wasting our money on bureaucracy. The private insurance industry has this huge bureaucracy that wastes money. So don't talk about it as saving money, talk about it as waste in the private insurance industry. Also, Medicare for all means we would have freedom of choice. Under Medicare, let me tell you about my mother-in-law, who was just here until a few days ago, actually. She lives in Florida. And there she is. Hi, Ma. Hope she's back happy and home and back in Florida. So she happens to have, and I have her permission to tell you, she happens to have a pretty rare, she has hokum, okay? So that's a pretty rare genetic, they think, cardiac disease that's actually potentially fatal. And she was getting, it doesn't show up until your early 70s in her case, or actually in her case, in her late 70s. She needed to have a cardiac ablation. And turns out there's only 3 places in the country that have done more than a handful of cardiac ablations in hokum. And one of those 3 places is here in St. Louis at Washington University, where they've done more than 90 now. And so we didn't want her to have this high risk cardiac ablation. It's not even a Purkinje ablation. It's giving her a small heart attack. We didn't want that to be done in a place and experience, so we brought her here to St. Louis, and it was done terrifically. She got some of the best care in the world, arguably, and it worked fine. Medicare paid for all of it. She could come here because she has Medicare, and she has a supplement as well. So it was paid for completely. 98% of physicians are in network. So she lives in Florida, but she was able to come to St. Louis to have this done by her choice. If she were living here and she had to go to Florida, or if my wife might have this problem, for all I know, she's too young to be diagnosed with it yet. But if she did have it, and if we decided she had to go to Florida to have it treated, we have Cigna. We have the best marketplace policy I could purchase, and I wouldn't be able to take her there because it wouldn't be in network. So I have the most expensive private insurance I can purchase, and it would not cover this treatment for me or my family. But my mother-in-law has Medicare and can. So if you talk about messing with Medicare, you get the unhappy look from my mother-in-law. So what are some data about this? How many? We all know that there's physicians who don't take Medicare. How many? Well, there's almost 700,000 physicians in practice in the USA a couple of years ago when I collected the data. And there's nearly 10,000 who don't take Medicare, so there are some. that means that 98% of physicians take Medicare, more than 98% of physicians. And that's important to know because you'll hear people say that there's docs who don't take Medicare, and it's true, there are thousands, but there are hundreds of thousands who do. So with Medicare, of course, you can go to any Medicare for all, you can go to any doctor anywhere and you're back in control. All right, what did I just do? I talked about feelings, right? So if you're sort of an anecdote person, you got one of those. I talked about facts. I gave you some numbers. I talked about sanctity. That wasn't just being cute. That was, probably wasn't cute, but that was sanctity. And I gave you a little authority figure. So I tried to apply these principles. And I'm going to skip this question about is healthcare a human right for time. And instead we'll go straight to this. This is from the Reverend William Barber, who said, he's brilliant. If you don't know this guy, you need to follow him more. And he says moral language, and gives you new metaphors. In other words, don't shy away from moral language. Use moral language and use it in this specific way. He says, for example, this: I'm against this policy, not because it's conservative or liberal. He says, I'm against this policy because it's constitutionally inconsistent, it's morally indefensible, and it's economically insane. Different way of talking about these topics. So how do you talk about moral values with conservatives? You bring up loyalty and tribalism. Bring up the people going overseas for healthcare. Bring up all seniors love Medicare. Why can't all Americans have it? Loyalty, tribalism. Bring up that healthcare is stifling American wages. Use the word America as often as you can in this discussion because there's much to be proud of, and this is a problem for America. Bring up sanctity and personal responsibility, that you should have sanctity and responsibility means you should be able to make your own decisions about your healthcare. And bring up prudence. Use that one-liner that I told you because it's true. The 25 studies show that Medicare for all would be prudent. Talk about it with anybody. How do you talk with anybody? The first thing to do, shut up and listen, which I'm not doing at the moment. But when you're trying to talk about these things with anyone, shut up and listen. And that's true when you're talking in an exam room with your patients about their health care. Shut up and listen. Physicians interrupt patients less than 23 seconds. Nobody gets their point across, and nobody wants to listen until they've said their piece. So shut up, listen to them, hear where they're coming from. Step two, while they're speaking, think through which of those 4 comfort zones is the one that they're in. Don't just react as a knee-jerk with your comfort zone. Think about which comfort zone they're in based on what they've said. And then step 3, think about the common ground. You may have to dig deep to find this common ground, but it's there. It might be digging deep in what they're saying, and it might be digging deep in what you're saying. But think about where that is. And then lastly, validate something of what they've said without necessarily reinforcing it. So say, something empathetic, you understand this, you sound angry or something about that, but don't repeat the conservative talking point because that actually just strengthens it. So here's how to get a hold of me, and that's what I wanted to talk about with you. So I think we can take questions. That was a lot, and I spoke quickly. You all still there?
Hello?
Hello?
Hello. Hi. That was great, Dr. Weisbart. Thanks so much for presenting all that information. If anyone has any questions, you can either say them out loud or you could communicate through the chat message. I just wanted to, in addition to thanking Dr. Weisbart, I wanted to mention that we have 2 more webinars coming up, one on the 21st that Dorothy Charles is going to give on single payer and the intersection of racial justice. And then on the 28th, Anad's going to give a talk on political advocacy 101.
So I did such a good job that y'all have all your questions answered. So someone asked, would there be a role for private insurers in a Medicare for all system? And that's a really important question. It would depend on how you choose to set it up. So the way I described it, no. But if in the interest of making it sort of a conversation that we could fit into a brief time period, I described one solution, which is taking Medicare, traditional Medicare, and improving it and giving it to everybody. And in that, there would be really essentially no role for private insurers. they would actually be specifically legally banned from selling anything that's in the Medicare for All program. So they could not sell insurance that covered primary care or that covered hospital or what have you. They could sell insurance for things that aren't covered, like if you only want to have a private room or something of that sort. They could sell that kind of insurance, but they wouldn't be able to sell traditional insurance under the way that I've spelled it out. So in most countries that do this, there still is a small niche for private insurance. They represent less than 5% of what the country spends, so that's fine. The way I sketched it out, there is essentially no role for them. Perhaps they could be claims adjudicators. I don't know. There's some, there's essentially no role for them. But there are other models, and there are other models. For example, would be in Germany. For example, they have it. It's publicly funded, but it's also more complicated. There are a myriad number of private insurers that are just incredibly regulated. So they're all nonprofit. They all compete on service, basically, but they all provide the same required benefits, and it's the same fee schedules, and it's much more cohesive. So you could do that. So there's the model I described. There's a model that does have a role for private insurers. That model still, like Germany, is still about a third less expensive than our model, but it's far more complicated than it needs to be. And it's of the single payer-ish countries, the countries that have gone down that road are the more expensive of those models. So you could do that. That's called an all-payer model. You could set it up those ways, but those ways are far less efficient and don't have quite the good results that you get with a true single-payer national health insurance, Medicare for all type model. So, if the country gets to the point where that's what the decision is of whether we have a single-payer versus an all-payer model, I'd be fine with how much we would have accomplished at that point. So, so there is a way, but it's not what we're talking about tonight specifically. How would you frame this differently when you're speaking to fellow physicians versus politicians versus community members? The core message is, of course, the same, but everybody has concerns about what's in it for me, of course. So physicians are often very interested when they see data that shows that Canadian physicians' salaries are quite competitive, if not better than they are here, that Canadian physicians are far happier than we are. We're actually the second least happy physicians in the world, that Canadian physicians don't have accounts receivable. The average physician in Missouri has $200,000 of accounts receivable. That's a year old. Canadian physicians don't have any accounts receivable. Canadian physicians' claims are all paid within 2 weeks, typically, 98% of them. They don't have this set of issues. Malpractice is a tiny fraction of the cost in Canada that it is here, largely because the most common reason to sue a physician is because of a bad outcome, be it our fault or not, a bad outcome. And when you have that, one of the things you're most worried about is who's going to pay the future cost of my medical care? I don't know. I'm going to have to sue. So if the future cost of your medical care is in the water because you live in that country, you have far less reason to sue. And the biggest piece of the judgment against a physician when they prevail is for the future cost of medical care. So when there is a judgment, it's a fraction of what it is here. And at the end of the day, the premiums for malpractice are a fraction in other countries, and physicians, American physicians, are the only ones talking about malpractice as a crisis. So that's how I talk about it with physicians. And of course, it's really easy for physicians to understand the problems their patients have when they can't get access to healthcare. Politicians, a very important thing for politicians to understand is how incredibly popular this is among their constituents. So there have been surveys shown that across the board, conservative and liberal, Democratic and Republican congresspeople, when asked to estimate how many people in their community support Medicare for all, consistently grossly underestimate the popularity, and they shy away from it when they don't really need to. So that's number one. It's important to understand how popular it is. Number two, they're often concerned about the economics, so we bring that up with them. And number three, show them this is actually becoming table stakes for running for office these days. In the Senate on the Democratic side, virtually everybody who's talking about running for president in 2020 has co-sponsored the Medicare for All bill that's in the Senate. So That's some of the messages that are good for them. For community members, I like to point out to them how crummy their insurance is today and how much better it is. So one of my most favorite opening gambits when I'm talking to a community is to ask people, raise your hand if you have insurance. And of course, a lot of, most folks do, because we have something like 90% of people in the country insured. And then I say, keep your hand up if you have good insurance. And they usually all keep their hand up. And I say, we know there's problems, but keep your hand up if it's good insurance. Okay, you all think you have good insurance. Keep your hand up if your insurance covers physical therapy. Some hands go down because they don't know. Keep your hand up, okay, the ones that have your hand up. Keep your hand up if it covers physical therapy for rehab after a stroke. They start looking confused. Keep your hand up if it covers rehab in the hospital or if you can get it in your house. Keep your hand up if it covers rehab in your house for more than 10 visits. And they start to realize that they've just said that they have good insurance, but they don't have any idea, because that's how insurance works. It's there when you don't need it, and insurance today disappears when you do. So those kinds of stories, when people start to scratch their head and realize, I think are pretty helpful. The biggest barriers in transitioning to a Medicare for All system, well, the biggest one in my mind is that no matter how clever and smart we are, we're talking about making an abrupt shift in 1/6 of the economy, or maybe more than that even. We're talking about overnight shifting that much of the economy. So when Medicare was introduced in 1965, healthcare was a much smaller percentage of the economy, and it was an add-on for uninsured seniors. So it wasn't nearly the thing that we did. This, we're actually talking about making a pretty important change, and I'm always worried about unintended consequences. So it makes sense to try to do it as quickly as we can, because and to stay focused on that. But I like the idea personally. This is me personally. This isn't the PNHP position. I personally would say that I like the idea of the bill that's in the Senate, where there's a 3 or 4 year thoughtful transition. Let's do this first, then let's do this, and let's do this. And it's on an aggressive timeline, but it's on a timeline so that you can course correct if something was happening that is not the way you expected it to be. So that's, to me, the biggest issue. Best source for facts to use and advocacy, well, dig into the PNHP website. It's incredibly robust. There's something here. You mentioned the cultural political change when you moved to Express Scripts. Would you share a specific example? No, actually, no, I don't want to give you a specific example of that. Just trust me, it's pretty conservative. So I think that's the questions, isn't it? Did I miss one? Oh, here's one. While cutting administrative costs may be attractive in terms of efficiency, it raised the concern for all of those lost jobs, right? Do you have a recommendation? Yeah. So there's some really important arguments to think about with jobs. The first is it would be a problem with jobs, but it's an incredibly small problem with jobs compared to the problem with jobs we already have. Far more people change. I mean, I don't have the numbers in front of me because I didn't think to pull it, but it's an order of magnitude or more people who change jobs every year in the United States today compared to the number of people whose job would be disrupted by this. So would there be some job disruption? Yes, but it's a much smaller number incrementally compared to what we have just as a part of the natural economy, number one. Number two, most of the jobs we're talking about, and this is not a judgment, but it's a statement of fact, are relatively crummy jobs. And by that I mean that they're jobs in the call center and in data processing, they're jobs that have 20 to 25% annual turnover today. I think the number is actually 25% annual turnover today. So that means no matter what you do today, 2 years from now, more than half of the people in the jobs that we're talking about are not going to be in those jobs anyway. And then the last piece to think about, of course, is that this would be the bills are very protective of them anyway. The bills talk about 2 years of income guarantee up to $100,000 a year if your job happens to be one of the ones that's displaced by it. But the most important piece about jobs is that this is jobs stimulant. This unbridles industry. This makes industry able to focus on the industry that they're actually trying to do. Every country that's done this has found a growth in their GDP and in their nation, and it would stop diverting resources to things that are ridiculous. We know companies in Canada, for example, who have their suppliers are in the United States and their clients are in the United States. So they are today importing their materials from the United States, processing them, manufacturing them, and then shipping them to customers in the United States. And they would love to relocate to the United States, but they can't afford to because that would create such a huge bump up in the cost of their providing employee benefits that they just simply can't stay competitive and do that. Businesses today describe healthcare in the United States as a chain around their ankle that makes them lose when they try to compete globally. So as a result of that, would there be job disruption? Well, yeah, sure, there already is in lots of other areas. We would protect against that, and it would be plenty. And we would need these folks to be doing a lot of other things. You know, we would need to be investing this money into social services that really have long-term benefits. So at the PNHP meeting, Dr. Wohlhandler said that the transition period in the Senate bill gets rid of a lot of the economic advantages made. So this is where you start to get to opinion. I would say that some of the folks within PNHP leadership, like Drs. Wohlhandler and Himmelstein, are probably a little more comfortable with the abrupt transition than I personally am. That's just me personally. I think they're probably right that delaying that making a more stepped transition would delay the benefits. Of course, it would delay the benefits, but I'm sort of a little bit less comfortable with the level of making an abrupt transition. So, you know, it's a dealer's choice. I mean, you know, and if that's the level that the answer gets resolved at, if the discussion around the country is, do we want to do this overnight or do we want to do this in a 4-year transition? If that's the decision point, I'm fine with any answer to that question, frankly. So, anybody else? I'd say the main argument against a slow transition is if it happened. So the bill in the Senate would commit to this transition. If you try to pass piecemeal parts, if you instead of having a robust omnibus bill as there is in the Senate, and instead say, let's not legislate a 4-year transition, let's just legislate this one part. Let's just legislate the public option. Let's just legislate lowering the age of Medicare. Let's just legislate this one piece, and then let's look at it again in a year. If that's what we passed, that would be a disaster, because then we would not be committed to a long-term road. People would be fed up with talking about healthcare, and that would be very corrosive. So I think that's an important clarification. If we did an incremental transition, it would have to be one that's spelled out at the beginning of here is the strategy, and that's exactly what's in the Senate bill is a 4-year process. And we're after 8 o'clock, so I don't know, we're getting probably near the end, eh?
Yeah, I want to thank you so much, Dr. Weisbart, for everyone out there who's attending. Thanks for sticking through the presentation. This is going to be recorded and put on the website, so if you want to share this with your staff chapters, that will be available to you. And, you know, tell everyone about how great these webinar series are, and we'll keep the momentum rolling with the next 2.